Welcome to Halteres Presents, a brand agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Thayer and Mickey Urdea.
Hello, my name is Rich Thayer, Managing Partner at Halteres Associates.
And this is Mickey Urdea, the founding partner at Halteres Associates.
Today we are joined by Mike Richey, who will be talking with us about the importance of community engagement to improve access to healthcare.
Mike has a wealth of experience in HIV. He's worked in this field for a very long time, all the way back to the beginning of the AIDS epidemic. And he's going to tell us a bit about work back then and more work recently to help identify individuals with HIV and engage in the community in access to HIV diagnostics and also HIV treatment. And with work he's doing with regard to the quilt that he'll tell you much more about.
And now our interview with Mike Richey.
Hi, Mike, and welcome to our podcast. We'd love to have you tell our listeners a bit about yourself.
Thank you. It's good to be back with you again. After 40-some years in the biotech industry, I'm now enjoying my life in sunny Palm Springs. And instead of working full-time, I'm actually working for things that I'm quite passionate about. I'm co-chair of the board of the National AIDS Memorial, based in San Francisco. And I've also been appointed to a task force to place an AIDS memorial in our new downtown park in Palm Springs. So that's keeping me quite busy these days.
It's fantastic.
Wow, good for you.
I think this topic we're talking about today, access to healthcare, is something I'm quite interested in. With the work we do at the National AIDS Memorial, we've identified reasons for HIV infections occurring at a much higher rate in certain populations. It's clearly due to stigma and lack of access to quality care. So it's something I think a lot about in that work that I do, and I'm happy to be able to talk about my experience in healthcare today.
That's great. So, Mike, in the richest country in the world, why do so many people have challenges seeking access to quality healthcare services?
There are actually many reasons behind that. It starts at the top with structural economic inequity. It's this disparity in economic conditions that really causes lack of access to healthcare across our society. In fact, in Los Angeles, the second largest city in the US, there are over 40,000 people that live on the streets each day there. In a recent survey, though, and strikingly, we found that 40% of those people have full-time jobs, saying that the ability to earn income to remain housed is outstripping their capability across a large set of the population in Los Angeles, even in our own state. Recently, the New York Times also published an article that there are about 500,000 people in the United States at any one time living on the street. And at the same time, over a year basis, 900,000 people are living in a homeless situation across the US. And while they are able to get 900,000 people into homes each year, at the same time, a new 900,000 people become homeless. So it's this equilibrium of, the billions of dollars we spend to try to address the lack of access to ability to afford a place to live for you and your family. At the same time, while they get new people or those people into homes, there's a new population of 900,000 people that become homeless during that same year period. And in addition to the economic instability and the disparity that exists at that point, systemic racism is a clear contributor to lack of access to quality care in the US. In fact, that within the Black population, mothers and their infants suffer a much higher infant mortality, as do the women who bear those children in the United States today. And that's independent of income. There was a recent article presented that Black women, regardless of their income, have a much higher rate of infant mortality and mother mortality in the United States today. In addition, there's this thing that we've been struggling with for our entire time in the healthcare industry, which is a lack of universal access to healthcare in the United States. In fact, the Commonwealth Fund did a study that found that the outcomes and the economic input in the United States, while it's the highest expense level, the outcomes are the poorest in all developed countries across the world. This remains to be addressed. And even with the improvements in access to healthcare that was afforded by the Affordable Care Act, with millions of new people getting access to healthcare, there still remain millions of people that have difficulty accessing that healthcare. And finally, I guess the other challenge that is really quite intractable is the geographic disparities. So in rural areas across the United States, it makes it really hard for some people to actually get to healthcare providers. And that's due to lack of transportation and poverty. The lack of transportation combined with poverty increases the barriers to care in these rural areas in the United States.
So, given these issues of the number of homeless individuals and geographic disparity, how does that manifest itself in some of the problems with regard to healthcare?
Well, as I mentioned, there are 500,000 people living on the streets in the U.S. At any one time, and a significant number of the unhoused people are population or people of color. It obviously makes it a real challenge to access healthcare in many cases when one doesn't have access, and it's a real challenge to maintain a routine involving taking medications, and not to mention higher rates of tobacco use, other substance abuse, poor diets, lack of exercise due to lack of built infrastructure, and safety matters in the communities, among other things. Poverty is a key driver of access to care, which lead to unhoused populations, poor quality nutrition, and lack of access to quality care. In many communities of color, there exist large areas that are considered food deserts without access to affordable, high quality food. And many of those lead to complications in receiving decent health care in those communities. And in many cases, as we know, many of the communities of color have had poor experiences when trying to access health care due to feelings of lack of trust with healthcare providers, especially for those who don't look like themselves.
Mm-hmm.
Yeah, that's a good point. Mike, you've mentioned the importance of understanding stigma and the impact stigma can have on access and treatment programs. And you've also mentioned PrEP. I'm just wondering if there is an aspect of stigma associated with PrEP, and if so, if that's something that you are working on programs to overcome.
Yeah, so stigma is derived from communities' past experience. Why is it that people don't want to go in and get HIV tested? Because there's been this whole cultural, in fact, it's rampant today with trying to make LGBT people feel marginalized again. It's, we thought we were well beyond this for the past 2 decades, and it's absolutely reared its ugly head because there are elements of politics that respond to that. Why is it that we're dealing with this transgender bathroom issue and lack of medical care for that community? It's just absolutely ridiculous. And it's caused by these individuals who find that they have a message that resonates with a base in their population that will drive change in their favor. And I think back to those segments of the population where there was forced sterilization going on, or those segments of the population where the African American community did not get access to care. In fact, they were thought they were involved in a clinical trial, but they were ignored. And there are just countless instances where, because of mistreatment, these barriers are raised in various different populations. So it's not just unique to the LGBT population. It's it crosses all racial barriers and societal barriers as well. I mean, why is STD testing verboten in Asia? It's just a societal construct that we have not yet figured out how to address.
So, Mike, what are some examples of efforts to address barriers to healthcare access?
In a number of communities, healthcare systems have started to invest in putting satellite clinics, getting the care closer to the patient. That's also, in another version, done through access to a mobile clinic. They basically outfitted these vans with access to sort of a mini doctor's office where they can do blood pressure and heart evaluation and perhaps some testing. The problem with that opportunity, though, is that many times they miss a number of preventable diseases because their menu is a bit small. So what they've started to do is invest more in the brick and mortar and lessen the mobile clinics because they need to do a broader band of testing to try to detect preventable illnesses across oncology, infectious disease, perhaps other situations, including mental health. Some of the struggles people are going through with mental health and substance abuse. So one of the things that's been done here in the desert is the DAP Health has a very active a health clinic here in Palm Springs, but they realized there was a population of individuals that were at risk for HIV, HCV, and other things in the eastern part of the desert in India. When those populations didn't have access to transportation or the funds to get to the clinic in Palm Springs, they actually built a new clinic down in Indio, 40 miles away, to actually improve the access to healthcare for their clients down there. They've taken that even a step further. I read this past week where they've actually considered bidding to buy a healthcare organization called Borrego Healthcare here in the Coachella Valley. It went bankrupt last year, and they've decided that it's their job to try to provide as broad a healthcare as possible to their thousands of patients that exist when they're in their healthcare system. So that's one example of how a very committed and well-funded organization in the desert is trying to do things to improve access to care for a large population of individuals here.
That's very interesting, Mike. One of the challenges that we've heard brought up many times is so-called loss to follow-up. So in the situations that you're just describing, what's being done to try to promote engagement from the patient perspective or from the individual perspective to stay engaged in these programs in the healthcare system?
That's a really age-old problem, is that when you get a patient in and then they disappear and you don't know if they've ever taken their medications or if they're going to come back for the follow-up that you've asked them to do. And I think that's one of the reasons that they've actually built out this brick and mortar clinic in India, so that they don't have to recur this problem of lack of transportation and cost and time. People have to take off from their job to get to the healthcare appointment. So I think putting the facility closer to the patient is one of the things that they're trying to do to improve that. In San Francisco as well, the health department has decided to take individuals into communities where there's a large level of homelessness in the Tenderloin. The health department is actually appointing these people that go into the communities in the homeless encampments, and they refer these individuals to linkage centers. And those linkage centers have access to behavioral health, testing for infectious diseases, testing for preventable cancers, and some access to some of the things that they know that particularly plague these communities that are large encampments of homeless people in San Francisco. So I'd be curious to see how well those end up working. It's been a big problem in San Francisco, as it is in Los Angeles, to try to address this head on with the lack of access to economic engine and healthcare that comes with that.
Is there anything to say at this point, Mike, about involving people within these subsets of the society in the actual outreach itself within their own population?
That's an interesting point, because the other thing they did in the Indio clinic, so this point of having people look more like themselves as they come in to seek access to care, is a real factor, I think, in getting people to trust their healthcare providers. In the clinic in Indio, not surprisingly, it's staffed by mostly Hispanic individuals, sometimes women, Hispanic women as well, to get people in that might be at risk for HIV or HCV or other mental health issues that occur in these populations. So they have a large effort out to increase the staff of Hispanic individuals, and especially Hispanic females, to begin to build the trust within those communities that they're serving.
Yeah.
Makes a lot of sense.
One of the other things, Mike, that we learned from talking to Native American, Indian reservation, that passed down generation to generation, because, when you think about it from a genealogy perspective, wasn't that long ago, the forced sterilization programs left such an incredibly bad impression, is the wrong word, but to this day, absolute total mistrust of any Western medicine, coming to try to help. And, how does Indian Health Services overcome that? What do you do? How do you there's still that barrier and that mistrust.
That's right. Yeah. On the syphilis story in Alabama, right? I mean, with the Tuskegee Airmen, they
Yep.
did complete injustice to those individuals that they were supposed to
Yeah.
be doing this clinical study with. So,
Yeah.
there.
Yeah. So, Mike, how do societal constructs and economics play a role in healthcare access? For example, some commonly cited issues would be psychosocial barriers to understanding and to access, local community traditions, stigma associated with the health condition itself, the historical impact from other prior interventions that perhaps were misguided or misdirected, privacy concerns, and others. Could you please expand on that some?
Um, Many people don't have health insurance, and therefore, for those individuals, many times care is obtained at the wrong place at the wrong time. Preventable illnesses are missed. They go to the most expensive point of care, oftentimes urgent care or emergency rooms. And so the lack of access to healthcare coverage causes much more morbidity, mortality in many of these populations. For those who are suffering emotional and mental illness as well, um, the fact that access to healthcare is associated with perceived threat to their personal freedom and shame in many of those cases. You know that today that you can hold someone in a hospital for up to 72 hours if they're considered mentally unstable, and many of these people have had challenges with that in the past in their life. So they try to avoid being associated with healthcare institutions. And in many locations across the U.S., populations don't seek care for preventable or treatable diseases due to stigma. In the situation where we talked about in the South, we've decided to take the quilt into these communities, begin to address stigma in those populations, so that people begin to feel less threatened by getting tested for HIV in cases where men have sex with men. They don't feel comfortable going into a healthcare clinic or seeking care in those situations. So this is also the case with cancer rates. It's while some cancer rates are roughly equivalent between white and black populations, there's a mortality rate among blacks is substantially higher versus white because they don't go to care as frequently as the white cohorts do as well. There are clear differences in how populations access healthcare due to many factors, including low income, low health literacy, long travel distances, lack of insurance, lack of paid medical leave, all contribute to higher rates of morbidity in certain populations.
So, Mike, it sounds like it's not just a matter of addressing access, because you can provide the brick and mortar, you can provide the clinics, you can provide any of the mobile testing units, but it's also understanding, as you were just describing, the psychosocial barriers. So what are, the other reasons why the individuals who are pregnant or who are sick or have exposure, to various diseases are not seeking care?
Yeah. I mean, we see this, for instance, in HIV testing again in Africa, for instance. The clinics are there. In many cases, they've done a pretty nice job of making sure clinics are available nearer to where people live. But certain subsets of the population are just never going to go to them, particularly men. It's a really big problem. So, how do you get to these people? What other things need to be done in order to convince people that they should seek the care?
And Mickey, I think you mentioned in certain Asian countries, while they do have STDs that occur, you can't call it STD testing. You have to test for the presence of a bacteria in order to actually accomplish the same effect, which is to identify those who are at risk or are infected with the organism so that they can be effectively treated.
Right. Stigma again.
Right.
Such a big issue. Mike, I'm thinking you have some personal experience with some of these things, like we were talking about with going into the rural South and meeting with people at churches and things like that. Be helpful to get some of your perspective about how this is all working from your personal interaction with people. You know.
So it's so interesting you asked that, because just this last week, the National AIDS Memorial had the next city in its southern uh, initiative begin to try to address this notion of stigma. They were in Louisiana, and they were in New Orleans and Baton Rouge. And one of the things that we've learned is that, first of all, it's not effective to have the CEO, who's a white guy, who deals with this issue on a national basis, to go into Louisiana or into New Orleans or Baton Rouge and tell them what we're here to address. So most of the people that are on the stage are people from HBCUs, the historically black colleges and universities around the area. They're individuals who actually have a community presence and are recognized as leaders in those communities. And they will only trust those individuals that they feel look like them. So, and the thing that we're doing in many of these cases is we're convening in churches a number of Black women, getting them together to do what they know how to do as a community, which is make quilts for those that they love. And doing it under the case where it's the AIDS quilt is we're able to actually break through that barrier because we're talking to them about a custom that they do routinely in their community. And making a quilt for someone that they've lost allows them to actually be able to talk about that for the first time and to be able to actually acknowledge that this painful experience exists in their community.
That's fantastic. That's just such a wonderful example. So, how do you think this will, or do you see any evidence that it has changed people's willingness to be tested or be treated or anything else? Or is that still going to take a while yet?
It's interesting you use that word because actually we've branded this initiative as called Change the Pattern. It's a branded effort that's actually been picked up by the media and reported in these communities where we're actually having this effect. And we're going to do some baseline testing to understand sort of what the testing rates have been in these populations, and then look down the road over the next year and see if there's an improvement in people accessing care, testing, and treatment if they're positive, or prevention if in fact they remain negative. So increasing awareness, trying to use that to bend the curve of the number of people becoming infected is really the metric that we're looking for, along with our sponsor Gilead, who is really committed to helping us end HIV in these communities.
That is fascinating, Mike. That's a great example. So, Mike, what are some examples of programs that have worked to improve individual and community engagement?
So this program that we're talking about going into the South to actually try to bend the curve of new infections, letting those people who look like the audience we're trying to serve be the messengers to those people, I think is the right answer to this, because we find it works in other populations as well, against different disease states. We're actually really focused on the South because the numbers speak for themselves. The highest rates of incidence of HIV occur in the Black and Latino communities, and we're going to try to expand this in other ways to try to begin to bend that curve. But we're also now not just focusing on the South. We've been asked by certain communities like in New York and in Florida, why don't you guys come and do the same work here? Because we've got big problems here, large populations that feel threatened to access healthcare, situations where people don't trust the individuals doing the work, and ways in which we can find common threads throughout the communities of that we're hoping to be able to address this reduction in HIV transmission.
Mike, is there anything to say about PrEP in association with this besides simply treatment?
So it is important to talk about PrEP because that is a big part of this. If we actually want to reduce the number of HIV infections, finding those people that are HIV negative and talking to them about the access to preventive care can be part of this changing the pattern. It's not only making people aware of the fact that we are able to address stigma, inviting their communities to put their arms around them and invite them in, but also within that same community, if you are engaged in risky behaviors, there's a treatment or the prevention method out there that's been widely successful. 99.9% of the cases have been prevented in those individuals that are taking the preventive medicine. So we're hopeful that we can not only find a reduction in people because they are finally getting tested, because they feel like they have a safe place to go, but once they find they're negative, to actually introduce them to the notion of prevention as part of that messaging.
Mike, part of the messaging from CDC around PrEP is to think about using the opportunity to also check for other sexually transmitted diseases, hepatitis, to monitor kidney function and other aspects. Are you feeling pressure or the opportunity in your program to expand messaging to include some of these other risks associated with HIV and HIV transmission?
It's not obvious in the work that we're doing right now to expand. We're just kind of early in the game here. We're probably 9 months into this. We don't yet have the data to actually point to the fact that we've been successful with this. But I do believe, to the point we made earlier, when you actually have a patient in front of you, why not do a broader array of tests to find out what are the preventable diseases they might be tested for, and let's do some of the basic routine chemistries and CBCs while we've got them there. They're pretty simple to do, pretty low cost, and have high impact information content within those simple tests.
Yeah. Is HIV self-testing a part of this as well?
So DAP Health down here that put the mobile clinic and the brick and mortar clinic into place has also been launching a big initiative to, if you want to do home testing, call this number, put just the QR code in your phone, and you can get HIV self-testing done in home. I don't yet have enough data on that to see how effective it's been, but I think I'm looking forward to seeing if it's been adopted by those that are at risk to lead them either to prevention, or if a positive, lead into treatment.
Yeah, yeah. All those people that won't go to the clinic right away, perhaps they'll test themselves at home and take the first step.
That's
Still
right.
got to get them to go to clinic after that, unfortunately.
That's right.
But now they know they would have to be going there.
That's right.
Yeah.
Mike, as your organization works with and trains various groups in the communities, what are some of the organizations you're looking to as you leave and go on to other communities to carry on your message and to keep the program sustained in the local community?
That's interesting because we actually have this outreach going into the community to try to create these ambassadors and these missionaries that once we leave, they can have the tools that we've delivered. They've helped us refine and use those tools for future initiatives to try to continue this effort in those communities. Because at the end of the day, this cannot be a one and done. It has to be an ongoing sort of cultural change that occurs within these communities to have the lasting impact that we hope to see.
Wow, that's amazing. That sounds similar to the community health workers or health extension worker program that one finds in sub-Saharan Africa. One of the challenges there, though they're incredibly enthusiastic individuals, very strong representatives of their community, is they're inevitably unpaid positions. So it's a challenge. It's very difficult for these champions, if you will, to continue delivering the message. Is that something that your program is able to address?
I think that's going to be a chronic problem for us, is how do you get the people who are maybe enthusiastic at the beginning, but that don't have the opportunity because they need to have a full-time job to get out, stay out of the homeless position. And so it's going to be a challenge, I think, to figure out the right formula to continue to incentivize. And maybe there's some money in a government fund that is focused on prevention that could help compensate these individuals for continuing to help prevent illness.
It's almost a public health message, Mike, right? It takes you away from any of the individual insurance approaches, the payer side of things, to more of a public health message back to local, state, federal governments.
That's
Again,
right.
just thinking out loud here because it's a very,
Yeah.
I mean, whose problem is that? I mean, who could even step up to be that supporting role that you're talking about?
To your point, Rich, it's not obvious who is the stakeholder that's going to benefit from that could fund such an effort.
Yeah.
Yeah.
Yeah, outside of NGOs or churches or something that, kind of have some of those roles. Yeah, but your program you're describing sounds marvelous and, written much larger than that. This is something that, a bigger effort's going to need to be behind to sustain.
Right.
Well, but you're working with Gilead. Why? Because they're going to sell more drugs as a result of this. So that's a completely logical relationship. So how do you think the things that you've learned and the things that we continue to learn about these issues will impact the design of diagnostic products or impact access to existing diagnostics?
I think it's an important question because, in fact, it's diagnostics contained within the whole healthcare industry. So there's a policy issue first, which means we can see the experience by the Affordable Care Act. We got a whole new population of people that got access to treatment and care. And if we can actually drive for policy that allows us to look more like the developed countries that have universal health care, I think there's a policy message there that we need to continue to go back and revisit. Because at the end of the day, if we can make universal health care a fact of life in the US, I think it'll go a long way to help address this notion of improved outcomes and quality of life. For diagnostic developers, I think it's important that we determine as an industry which are the highest impact tests that we have: clinical chemistry, CBCs, STDs, infectious disease, et cetera, and look at that and deliver as many of those tests as possible in as low barrier to entry. In other words, easy to use with the lowest cost possible. And I don't know what that looks like. I'm sure it's the holy grail still in the industry. I'm glad to see that things have moved in that direction as a result of the investments in diagnostics around COVID. But I think the industry can really benefit from looking at that big question about how is it that we can do the most care provided by diagnostic information at the place where we see the patients most often. And I think for payers, at the end of the day, as we all know, the payers are going to have a big place in this. And I think we've got to look to the payers to find ways to incentivize providing the broadest number of tests that have impact at the point of care for the best reimbursement to incentivize this change in the industry. So I think all across the policy, the diagnostic manufacturer, and those who pay for it, there got to be commitments to see these changes occur.
It's very interesting, Mike, and we just have seen all the changes in diagnostic platforms that have occurred over the course of the pandemic to drive the use of testing initially for SARS-CoV-2, but now for other things as well, to the broader population. We haven't completely seen that transition to the lowest cost, because a lot of people came out with things that just happened to work. They were getting paid a lot for it. But now, the governor's about to come off and they're going to have to compete on price. And I just hope that what you're talking about becomes much more of a reality now because of all that effort. Very inexpensive lateral flow assays or other platforms that can be instituted very broadly. People can carry them in their pocket when they go see the population. Leave them off in various centers that where people can just take them out of a bowl and take them home. That's a vision that's been important in global health overall for a long time. But we have exactly the same problems in the United States in many locations that you can find in the most remote places on Earth. They are healthcare deserts, and we need tools like this in order to make it possible to give people initially the diagnosis and then the care that they require.
And for goodness sake, how many times have you ever had, in my own closet, I have a shelf of COVID tests right now that are there for any need I have. And, this is the first time in my life I've ever had that kind of thing there because I needed it to continue to carry on a life that I felt was safe and respectful for others and knowledgeable. So if we can take that same principle and apply it to high impact diagnostics across a broad spectrum at reasonable cost, I think there's a tremendous opportunity for all of us.
Yeah. Fantastic. We need it.
We need that. Thank you, Mike.
Thank you.
Very good point. So thank you, Mike, for being on today. Your program with the AIDS Quilt sounds extremely exciting. I look forward to hearing future updates on how well it's going and some of the outcomes that you're receiving.
Yeah, thanks, Mike. We've worked together for so many years. It's been great to have this conversation with you and catch up a bit. But also, your wealth of experience has just been wonderful to hear about, and just congratulations on the progress so far with you and your team. And we just hope you're going to continue to be able to find the funding and make the progress that it looks like you're making. So it's just a great situation. Thanks so much.
Thank you all for the opportunity to get to re-engage with you again. And it's been a real pleasure and I look forward to more of these in the future.
Very good. We'll be in touch.
Thank you and goodbye, Mike.
Thanks.
Halteres Presents is produced by Halteres Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Halteres Associates is not responsible for any errors or omissions or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Halteres Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Halteres Presents.